When patients are transferred, they experience forces, and this can be in the back of the ambulance, this can be in a helicopter, or this can even be in an aeroplane. And I hope you can remember your A-level physics for this next section. When patients are transferred, they'll experience three main forces, and this is acceleration, the gaining of speed, deceleration, slowing down or braking, and also vibration as well, which is one that you might not always think of. Let's have a look at how these might affect somebody. So this probably looks a little bit complex, but let's just run through it, and it's really quite simple. The one key rule that you need to remember is that for every force moving in one direction, there is a reciprocal force moving in the other. So for instance, let's imagine that we're accelerating in a car, moving this way forward. We feel another force in the back where we're pushed into the back of the seats. Likewise, when we're taking off, going on holiday in an aeroplane, the force that is happening is we are accelerating upwards, but we feel it, the reciprocal force, in the bottom where we feel heavier. And it's these reciprocal forces that can have a big impact on the patient's physiology, and especially those who are critically ill. Acceleration is probably one of the primary forces that your patient's going to feel in the back of the ambulance, probably because you're trying to get somewhere quick, perhaps the emergency department. We can divide these up into long or short durations of acceleration. Long is over 2 seconds and short is less than 1. But these accelerations can have profound effects on your patient's physiology. Long accelerations can cause rapid shifts in fluid, which in your hypovolemic patients is probably going to push their blood pressure even lower, but it can also cause movement of the vital organs. This can cause things like reflex bradycardias and hypotension as well. And there are some planes that we looked at earlier which are least tolerated. Unfortunately for you guys in the back of an ambulance, the least tolerated is the negative GZ to the positive GZ, and that's going from the head to the toes. Generally, your ambulance patients will be either supine or slightly head up, but this position causes most of the problems with fluid shifts, drops in blood pressure, and movement of those vital organs as well. So knowing about the effects of acceleration is really important. The reason for this is that this area is obviously bigger from head to toe, and there's more space for the fluids and the vital organs to shift as well. And the physiological effects that the patient will experience are different depending on if the force is applied to the head, the GZ axis, or to the feet, the positive GZ axis. And this axis, as I said, is the least tolerated of all axes. So let's take a look at how this might play out when you're responding to an emergency and how these forces are affecting your patients. Generally, the head of your patient would be here in the ambulance, with their feet somewhere around there if they're laid supine. When we're accelerating along the GZ axis, moving this way, the predominant force that's going to be felt is in the patient's feet, as we're moving this way. When we're decelerating, i.e. if you're braking, the predominant force is here and is going to affect in the patient's head. And this can have some profound effects. Generally, deceleration, so that force in the patient's feet, is less well tolerated. And the reason for this is that it increases the venous return. And what happens as you're braking, the blood is then rushing towards the head, and it's causing a raise in the ICP and a reduction in the lung volumes as well, as the diaphragm moves up, and the lungs also compress because of this as well. So when you've got a patient with a head injury, it's advisable that you try and do as little braking as possible. Or if you do brake, try and preempt it and try and slow down steadily. And this should hopefully reduce the impact that it has on the raised ICP and the increased venous return. Acceleration, i.e. the force happening at the head and moving things to the feet, is more tolerated than deceleration. But what you can find with this is that you get a fall in the blood pressure as the blood moves from the head to the feet, and this can also reduce the cerebral perfusion and cause patients to get lightheaded. So rapid acceleration is also a bad thing, and that's why when we're transporting patients in the clinical setting, we try and have a smooth departure and a smooth arrival, and try and minimize any rapid deceleration or acceleration. Remember, in the fit and healthy patient, this isn't too problematic, but you might be dealing with patients who are profoundly hypotensive because they're critically ill. They might already be decompensated from extensive time on the ICU, but also they might have an infection, sepsis, that's altering their metabolic rate as well. And these patients are really likely to decompensate further in the ambulance or in the mode of transport. So having said that, how can we actually start to limit some of the effects that these forces are having on patients? And when we transfer critically ill patients, the first thing that we do is plan the intervention really well. As I said before, it's an MDT approach, usually between an ambulance service and intra-hospital services as well. And we need to plan the routes, we need to plan what we're going to take with us in terms of equipment, but also we need to plan for anything that's potentially going to go wrong along the way. And sometimes we have to make interventions early in the hospital, anticipating that the patient's going to deteriorate. One thing that you can do in the back of the ambulance, if your patient allows, is actually to head up, tilt them, or alter the position slightly. But what this will do is it will actually distribute the forces on your patient as well, and you might find that they tolerate this better as well. Being laid supine is actually quite uncomfortable, and coupled with the forces, it can actually provide a quite uncomfortable patient journey. So try sitting your patient up a little bit if they allow it. Also, what we can do is try and ensure that things are ready for those blood pressure drops. So we can ensure that we've got an IV fluid bolus ready, that we've got a reserve cannula, but also we can ensure that we've got a vasoconstrictor available as well if we're transferring a patient from ICU. And we can try and manage their blood pressure during the transit as well. Like I said before, one of the mainstays is that having a steady transport, so steady acceleration and deceleration to try and minimize those forces that are occurring for the patient. And also what we need to do sometimes is we need to consider the choice of route as well, and consider the injury type or the severity of the injury as well. And in transfers that I've done, we've sometimes had to take the longer routes. For example, when I transferred a patient from Castle Hill Hospital to Leeds General Infirmary who was on ECMO, which is a form of cardiopulmonary bypass, we actually opted to take a route that was going to take us 20 minutes longer because it was smoother. There was less turns, there was less chances for acceleration and deceleration. So sometimes it's actually better to take a longer route to ensure that these forces don't affect the patient as severely.